This lecture will cover lower respiratory system infections in general. We will talk about acute bronchitis, bronchiectasis, pneumonia, fungal infections, and empyema. Bronchiectasis and empyema are not real common, but you might see people with these at kindred, so I do want to touch on them. Acute bronchitis is an extension of an upper respiratory infection involving the trachea, and it is usually viral in origin. However, it can be bacterial secondary to an infection following a viral URI. So if you get a cold, which is a virus, and the infection extends down to the trachea and becomes bacterial, then that is bacterial bronchitis. What happens is the mucous membrane lining becomes irritated and inflamed with the infection, and it produces excess mucus, which results in congested airways. So if you look at this picture of two airways on the slide, you've got a normal airway, which is wide open, and then you have a narrowed airway with the inflammation and the swelling, and then the excess mucus clogging up that airway. Early symptoms are very similar to the common cold, and you get a deep, productive cough, very deep chest sort of cough. The treatment is humidification with warm or cool moist air, cough syrups such as cough suppressants, and mucolytics to help thin the mucus and get it up. Also bronchodilators to open up the airways. Chronic bronchitis occurs if you get bronchitis more than 3 months out of the year for 2 consecutive years. So most people just have acute bronchitis and they get over it. But if you are a smoker and your airways are irritated chronically anyway, then repeated bouts of acute bronchitis can lead to chronic bronchitis, which is one of the forms of COPD. This is another diagram of normal lung, which you can see all the alveoli and their little sacs, grape-like clusters. And then compare that to bronchitis. You've got inflammation and copious secretions in your airways. And what happens is these secretions block the airways, as you see in the little cutout, and the alveoli are deflated because they don't get any air in them to keep them open. And so they're obstructed by the secretions. And no gas exchange takes place in those obstructed, deflated alveoli. I'm including bronchiectasis in this presentation, not because it's common, but because it's something that you may see in the respiratory patients that you'll be seeing at kindred. This is a chronic condition, and it's when one or more bronchi are permanently dilated. It can be localized in one bronchus or it can be spread throughout the lungs. What happens is the muscles in these dilated areas become very flabby and they get scarred. And also the ciliary function is decreased. So what this does is this causes secretions to pool, and it can be very difficult to cough them up. When you have the pooled secretions, this creates an environment where bacteria can grow and infections are common. This occurs secondary to another chronic respiratory disorders such as cystic fibrosis, asthma, TB, bronchitis, and sometimes after toxic chemical exposures. So, as I mentioned, what you get is you get frequently recurring infections with copious amounts of sputum. You, the treatment focus is keeping the airways clear, controlling the infection, and sometimes they'll use azithromycin as a long-term prophylaxis to keep infections from occurring. Also treating the underlying problem. So if TB or cystic fibrosis, things like that, if you treat those, it will help this. And of course, always antibiotics to treat acute infections. Bronchodilators are helpful, and mucolytics are also used to make sure that that mucus is thin and easier to get up. Chest physiotherapy is important. You can use the vibration, the cupping, the positional drainage, really important for kids with CF. And then that vest is also good for kids with CF or older people who can't tolerate the chest PT. Health promotion measures absolutely include vaccines. You need a pneumonia vaccine and an influenza vaccine because that can really be a problem in people who have this. You can have surgery. If it's severe and localized, you can just take out that bad part of the bronchus surgically if you need to. Now we will move on to pneumonia, which is the most common respiratory infection that you will see, especially at Kindred, in your clinicals at Kindred. So this slide talks about all the different classifications of pneumonia. It's either classified as community acquired or hospital acquired. And these are caused by very different organisms. The bacteria that you find out in the community are very different than the bacteria that you find in a hospital or a healthcare acquired pneumonia. So hospital acquired pneumonia usually is defined as occurring 48 hours after admission to the hospital. So you have to be there at least 48 hours before getting the pneumonia in order for it to be classified as hospital acquired. Ventilator associated pneumonia is a special case of hospital acquired pneumonia. So you're in the hospital and you're on a ventilator, and then you get pneumonia while you're on the ventilator. You'll see that quite a little bit with national patient safety goals, and there are also patient care bundles that they use to take care of ventilator associated pneumonia. A lot of prevention is associated is put in place now to keep ventilator associated pneumonia from happening. They know now that mouth care is very important for people on ventilators to keep them from getting pneumonia. And so you will hopefully see a lot of these things in place when you're taking care of people at clinical. Community acquired pneumonia is usually less serious than hospital acquired pneumonia. It's usually something that can be treated as an outpatient, although you do see people occasionally as an inpatient for a community acquired pneumonia. And then finally, healthcare acquired pneumonia, which is different than hospital acquired pneumonia, is when this would develops in outpatient settings or nursing homes. So if you've got somebody who gets the infection in a skilled nursing facility, they call that healthcare acquired pneumonia. And again, it's a different organism than you'll see in community acquired pneumonia. Evidence-based practice tells us that researchers are rethinking the classifications that I listed on the previous slides. You'll see these in your textbooks. This is the nomenclature that you're going to be talking about most frequently in the hospitals, but the newest work now is that maybe these classifications aren't such a good idea. Maybe we shouldn't put all of these things in boxes. Maybe we should look at the big picture, look at the causative organisms. Everybody's different, and everybody should be treated as an individual. What we have done is we have looked at healthcare associated pneumonia or hospital acquired pneumonia and lumped it all into one big bucket and assumed that it's probably going to be MRSA or some other antibiotic resistant organism. And the truth is, researchers have found very little of it is MRSA. So if you think it's facility acquired, you've got to empirically treat before you get a culture. And so everybody gets vanco. And unfortunately, not everybody, once they isolate the organism, gets backed off the vancomycin and gets a different drug. And so the result of treating all of this facility-acquired pneumonia is far too much vancomycin is used for too long on too many people. One of the problems for that is, of course, increased antibiotic resistance to vanco, which is a big problem, but also it is really toxic. It can destroy your kidneys. It's very hard on people. You can't give it for a long time through a peripheral line. You have to have a central line because it's so hard on your veins. I mean, there's just a lot of reasons not to give vancomycin unless you have to. The other thing to think about is the flora of every building is different. Every nursing home has a different flora. Every hospital has a different flora. We used to think Pseudomonas was a big deal. There's really not very much Pseudomonas around anymore. So, it just depends on where you are. So if hospitals are doing, and nursing homes actually are doing what they should, is they're sending in those cultures, and then hopefully the health departments are looking at those cultures epidemiologically and developing a profile for that building. And so when somebody down the hall turns up with a pneumonia, you're looking at the bacteriologic profile of that building and thinking empirically, what should I give this person based on what normally grows out of people who live here or who are residents here, who are patients here. And so this is the new thinking. You may not hear about it for a while, but I thought I should let you know, since I think it's pretty important to stay on top of the latest research. So then what is pneumonia? Well, you'll see on this x-ray, the red arrows are pointing to the area of consolidation of the lung tissue that in this case is the pneumonia. It looks to be maybe right middle lobe, right lower lobe pneumonia. So pneumonia is an extensive inflammation of the lung, and you either get consolidation of the lung tissue as it fills with exudate, or you get interstitial inflammation and edema. So it can be caused caused by a virus, a bacteria, fungus. Any of those organisms can cause a pneumonia. Viral pneumonia doesn't produce the exudate, and exudate is just another word for pus. Sputum. Viral pneumonia doesn't do that. It causes the interstitial inflammation. So interstitial meaning inflammation in the cells, in between the cells, and they become swollen and inflamed with the viral pneumonia. It also tends to be less severe than bacterial pneumonia. Bacterial pneumonia produces the exudate, the sputum that they need to cough up. There's a concept map in your book that talks about pneumonia. So we talked about the classifications of pneumonia depending on where they occur and what organisms are causing them. Another way to there are other classifications of pneumonia too. Aspiration pneumonia is depicted here in this diagram, and that is one of the most frequent things you will see if you work in a long-term care environment and take care of older adults. Aspiration pneumonia happens when you have a reduced gag reflex or impaired swallowing. This happens with age. This also happens as a result of a cerebral vascular accident. It can also happen with alcohol. So you have people who drink too much, pass out, vomit, and aspirate. It can also happen after general anesthesia. So recall, what do we do with people when they're recovering from anesthesia? We turn them on their sides. We don't give them anything to drink until the gag reflex appears, or we sit them up a little bit to keep aspiration from happening. This can happen during a seizure. It can also happen with gastroesophageal reflux, because you're having reflux of gastric contents and you can aspirate that. Hypostatic pneumonia is something that we talk about as a complication of immobility or bed rest. What happens is secretions pool in the dependent area of the lungs, and that gives a place for the bacteria to grow. Finally, chemical pneumonia happens when you inhale irritating gases. You hear of people who've been in fires having smoke inhalation, or if you're exposed to some sort of toxic chemical during an occupational exposure. So who is at risk for pneumonia? The very young are at risk, and people who are older adults over the age of 65. Immunocompromised people are at risk because they may, whereas someone with a normal immune system may aspirate something and their immune system can take care of it. If you're immunocompromised, your immune system won't be able to. So that includes people who are immunocompromised because of disease like HIV, who are immunocompromised because of treatment, because of cancer chemotherapy, or some of these new biologics that are coming out to treat autoimmune diseases like rheumatoid arthritis and Crohn's disease. Those sorts of things immunocompromise you and make you at a very high risk for pneumonia. In fact, if you are familiar with the Muppets, that is how Jim Henson died. He was on a biologic, he was otherwise healthy, but got an infection and pneumonia, and his immune system couldn't mount a response to the pneumonia, and he died very quickly. So those biologics are great for the autoimmune diseases, but you really have to be careful with infection control. Alcoholism, because of aspiration, and also because alcoholics are quite often malnourished. And then, there's a lot of underlying diseases, especially chronic lung disease, COPD, pneumonia, those sort of things. How is pneumonia transmitted? It's transmitted through the cough of an infected person. Also, and this is important in your hospitals and skilled nursing facilities, it's transmitted by contaminated respiratory equipment. So that's really something to think about when you are taking care of people with trachs, or who are intubated, or who get oxygen, supplemental oxygen delivery. You can get pneumonia from infections in other parts of the body. Often happens from an upper respiratory infection or a sinus infection that moves down into your bronchus and your lungs. There are other ways that you can get pneumonia. Dental infections actually is another one of those ways. You can also, of course, aspirate bacteria from your mouth, pharynx, or stomach and get pneumonia that way. So what happens to your lungs when you have pneumonia? Well, what happens is when you have an infection that settles in your alveoli, the microorganisms multiply and they release toxins. And these cause inflammation and damage the cells in the alveolar membrane. So go back to pathophysiology and remember what happens during the infectious and inflammatory process here. So when the alveolar membranes are damaged, this causes edema and exudate from all of the dead white cells and other things that leak out of the cells. This fills the alveoli and reduces the surface area available for gas exchange. So the whole deal here is there's a decreased area for gas exchange. Some bacteria can actually cause necrosis of the lung tissue. This is called necrotizing pneumonia, and it's a bad deal. Uh, Pneumonia can either occur in one lobe, which we call lobar pneumonia, and if you recall the x-ray that we saw a few slides back, that's probably a lobar pneumonia, or it can be scattered throughout the lungs, and they sometimes refer to that as bronchopneumonia. Most healthcare associated pneumonia or hospital acquired pneumonia is scattered throughout the lungs, and it can be very serious. Sometimes you'll also hear the term walking pneumonia. It's a lay term, and basically what that means is it's pneumonia that's not serious enough that you are completely down and hospitalized, but that you are out walking around with pneumonia. And so this picture on the slide here gives you a good diagram of the inflammation in the alveolar walls, and the green stuff is the exudate that's in the alveoli, so you can see how the area for gas exchange can be reduced significantly depending on how much of the lung is involved. So here again is another diagram comparing the normal lung with its healthy alveolar sacs to a lung that has pneumonia. So you see the area of consolidation there, which is what you saw as that white area on the chest x-ray a few slides back. And then if you look at the little circle that's blown up, what you see are the alveoli that are consolidated and filled with fluid, bacteria, red blood cells, white blood cells, all manner of stuff that makes up the exudate. This decreases the area for gas exchange, and this is what makes pneumonia such a dangerous condition for people who already have chronic lung disease. So if you think of somebody who has chronic bronchitis or emphysema, who already has limited area available for gas exchange and the limited ability to move air in and out of their lungs, if you get a part of that lung that is consolidated with pneumonia and that takes away more area for gas exchange, this can really be a serious condition. And I challenge you, when you're at Kindred, to look at the charts of the people that you're taking care of and that your classmates are taking care of, and find somebody who doesn't have or hasn't had some kind of pneumonia. And that will give you an idea of the prevalence of this in people with chronic lung conditions. Now, bear in mind, you are looking at a very skewed population here. This isn't the general population. These are the people who've been in the hospital and were so sick they couldn't get out of the hospital, and so now they're at Kindred. But the point is, this is what makes people so sick and keeps people so sick, and quite often the reason they're there in the first place. So what are the signs and symptoms of pneumonia? You will usually see a high fever. This is often accompanied by chills and diaphoresis. You'll see someone who's dyspneic because of the secretions in their lungs and the decreased area for gas exchange. Also a lot of fatigue because of the dyspnea, and also just general fatigue due to the infection that's going on in their body. Bacterial pneumonia produces a cough that has rusty or blood fleck sputum. The sputum can also be yellow, green, even sometimes brown, depending on the organism, and can sometimes be pretty foul smelling. People will get chest pain, and we call this pleuritic chest pain, that is made worse by respiratory movement. So the pain gets worse with inspiration. General feeling of malaise, just feeling bad, achy muscles. These people can be really very sick. On physical exam, you will hear crackles and wheezes because you've got exudate in the alveoli, so there's air moving through fluid, and sometimes you'll get the exudate blocking the airways, and so that's you'll get the wheezes from that obstruction. Some older adults may not exhibit these expected symptoms, and we call this an atypical presentation. So when you get new onset confusion or lethargy, or you get people who have dementia who have an acute behavior change, anytime you see fever, and remember, older adults don't get a high fever, so even a mildly elevated temperature, new onset dyspnea, this should always cause suspicion for pneumonia in older adults. Now, some bacteria and many viral pneumonias also will cause atypical symptoms. You'll get fatigue. You'll also get a sore throat and nausea and vomiting just from the virus, but then you'll get a dry cough because remember, viral pneumonias don't produce exudate. They produce interstitial inflammation in the alveoli, and so you don't have that exudate to cough up when you have viral pneumonia. There is a two-pronged diagnostic approach to pneumonia. Always a chest x-ray because that is the definitive diagnosis. You can see the consolidation on the chest x-ray, as you saw back a few slides ago. And that will tell you whether or not you have pneumonia. Then you need to figure out what kind of pneumonia you have. So you do a sputum culture to identify the causative organism. Now, you don't wait until the culture comes back to treat. You start with empirical therapy, and then when the culture comes back, then you change the therapy to something that is more sensitive, that the causative organism is more sensitive to. If you think back to pharmacology, what is empirical therapy? It is when you prescribe a broad spectrum antibiotic to cover what is most likely the causative organism. And then after the culture comes back, you can switch that to something that the causative organism is sensitive to. Your empirical therapy will be different depending on where the pneumonia came from, because as you recall, the causative organisms are different in a community-acquired pneumonia than they are in a pneumonia that's acquired in a healthcare environment. So a word here about some cultural considerations with the pneumococcal vaccine. Routine use of this vaccine is not recommended for persons of Alaskan Native or American Indian heritage unless they have an underlying medical condition such as chronic lung disease, liver disease, or renal disease. Check out the vaccines PowerPoint to learn more about this vaccine. Therapy for pneumonia, as I mentioned earlier, starts out with a broad spectrum antibiotic, started as soon as the cultures are sent to lab. So you take the culture first before you give your first dose of antibiotic. Then when the cultures come back, the antibiotic may be changed to something that the organism is a little more sensitive to. You can be treated with oral antibiotics at home for community-acquired pneumonia. If it's a more serious pneumonia, or if the person is older, has underlying chronic illness, IV antibiotics and hospitalization with supplemental oxygen may be required. Rest and fluids are very important. If you have viral pneumonia, rest and fluids. Sometimes they'll use an antiviral. Expectorants to liquefy Those secretions help them get it up. Bronchodilators are important to keep the airways open, and analgesics for the fever and the aches and pains. And supplemental oxygen will be used if needed. So they'll keep an eye on the oxygen saturations and then give oxygen if the oxygen saturation drops. So this slide talks about nursing management of pneumonia. Your priority diagnoses are here. Impaired gas exchange. Think of the pictures I've shown you of those little alveoli that have reduced area for gas exchange there. Ineffective airway clearance because of all of the exudate present in the airways, and also activity intolerance because you do have impaired gas exchange and because of the fatigue that's associated with pneumonia. So if you look at this list of interventions, promote oxygenation, this of course can have to do with applying supplemental oxygen, but it can also be as simple as having them cough and deep breathe, move those secretions, open those airways. Use that incentive spirometer if you need to teach them good controlled coughing techniques. You want to control their elevated temperature with antipyretics. Nutrition and fluid intake is really important. Fluid to liquefy the secretions, and nutrition because people are just really tired. They don't feel like eating. They don't have an appetite, and they need that nutrition to be able to heal. Rest is so important for these people. Pneumonia can just really knock you down, even if you're a healthy person. I know people who have said they don't feel like themselves for several months after they've had a particularly bad pneumonia. Of course, you're going to monitor their vital signs, respiratory status, with particular attention to oxygen saturations and to their breath sounds and respiratory effort. They, as I mentioned, have a lot of pain, pleuritic pain, and so they would be less likely to take a deep breath, and so make sure you're relieving that. Good oral hygiene, so important, especially if you've got people on a ventilator. And then you don't want them to be around people who are smoking, or God forbid they should not be smoking, because that will just provide further irritation of the lungs. And then also making sure to avoid any other secondary bacterial infections. Most healthy people with community-acquired pneumonia recover without complications. However, there are a number of complications that occur after pneumonia, and a big surprise to you, I know, people who are most at risk for those complications are people with other chronic illnesses, people who are older adults, and also people who are immunosuppressed. The people really at risk are older people with chronic lung disease, such as COPD and asthma. So one of the complications of pneumonia is pleurisy. Pleurisy is an irritation of those pleural membranes. Recall that your lung is surrounded by two membranes, one pleura that is parietal pleura that attaches to the lung tissue directly, and then the visceral pleura that is the sac around the lungs, and in between those two membranes you have pleural fluid, and that fluid lubricates the movement of the lungs when you breathe in and out. When those pleural membranes are inflamed, as in pleurisy, that causes friction and pleuritic pain. So you'll hear a friction rub when they breathe in and out, and then you'll also get a sharp pain on inspiration, what we call pleuritic chest pain. An abscess is when the infection localizes and walls off. Pleural effusion is a collection of fluid in between those pleural membranes. So recall I said that you just have that little bit of fluid there. This is when you get more fluid there. And an empyema is a special case of a pleural infusion, and that's when you get pus in the pleural space. And so that's when the exudate or the pus from inside the lung actually travels out into the pleural space. The problem with this is, of course, is that it pushes up on the lung tissue and restricts lung expansion. Atelectasis is when your airways collapse. Quite often the alveoli will collapse beyond the part of obstruction or the point of obstruction where you've got secretions obstructing the small airways, and that further decreases the area that you have for gas exchange. Sepsis is when the causative organisms cause bacteremia. You get bacteria in your blood, and that disseminates to the rest of the body, and that can cause a septic shock. It can also cause what they call metastatic abscesses. So it can cause little abscesses in other parts of the body. And then ARDS, adult respiratory distress syndrome, is sometimes a complication of sepsis, but I suppose you could have it after a pneumonia and not be septic, but it's when your lungs get really boggy with exudate. They're almost completely filled with exudate. If you look at a chest x-ray with ARDS, it is completely whited out, and there is no area for gas exchange. Your lungs are very stiff, and there's a high mortality for that. The other thing that can happen finally here is that the exudate can organize and destroy lung tissue. So you can have what we call, remember, necrotizing pneumonia, where it will actually destroy the tissue, and then you get fibrosis there, which means there is absolutely no chance of gas exchange ever occurring in that area of the lung again. I'm going to talk specifically about empyemas here, not because they are common, but because this is something you will probably see in at least one or two patients during your time at Kindred. So, as I mentioned previously, an empyema occurs when there's a collection of fluid in the pleural cavity and it becomes infected and the exudate becomes very thick and purulent. You can get an empyema without a pneumonia, but it is very frequently caused as a complication of pneumonia. So you can see from that little picture there, it's an accumulation of pus in the pleural space. So it's basically a pleural effusion that is infected. As I mentioned, it's usually a common complication of pneumonia, but it can also be a complication of TB, or it can be a lung abscess that can drain out into the pleural space. The causative organisms can be anything. I mean, I've got staph and strep listed here, but really whatever's causing the pneumonia, or the tubercle bacillus or whatever, lots of different things can cause it. You treat it like you would treat a pleural effusion, which sometimes means you tap it. So you'll do a needle aspiration and take the fluid out that way. And then, of course, also you need to emphasize resolving the infection. So treating whatever infection is there, whether it's pneumonia, TB, whatever. Sometimes they will actually put in a chest tube to drain the area because there's so much exudate there that the person's lung can't expand enough, and they will put a chest tube in. So some older adult care points here. We talked about this a little bit earlier. They are more at risk for influenza and pneumonia because of a less efficient immune system, because their cilia have decreased action, and so they're not able to sweep out the invading bacteria like a younger person can. And then also they just generally have decreased elasticity and muscle tone, so that they aren't able to deep breathe as well, they aren't able to cough as well. Again, just to reiterate, confusion is often the most obvious sign of atypical pneumonia in older adults. And I will add to this behavior change in someone who has a cognitive impairment. So if you have someone with dementia and their behavior all of a sudden changes, think about pneumonia. It may take 2 to 3 months after a bout of pneumonia for an older person to resume their normal activities without undue fatigue. Remember, I said this really wipes even normal healthy person, but an older adult, it may take even longer. So continuing to talk about older adults here, very old patients may never quite regain the former level of wellness they had after a serious episode of pneumonia. If you think about the changes in your lungs that can occur after a pneumonia as a complication, maybe the fibrosis and the decreased areas available for gas exchange, this can really be a problem. And so because of their diminished immune system and the other factors that we talked about in the earlier slide, really talk to your older adult clients to have them seek medical attention quickly if they get signs of pneumonia, and also talk to the family members, especially if you've got somebody who is out in the community caring for an older parent. Teach them, person just doesn't really look right, something's a little wrong, get it checked out, because pneumonia can progress very quickly in older adults. Finally, I just want to talk a little bit about fungal infections. They are caused by inhalation of a fungus or the spores, or by overgrowth of organisms that are normally found in the body. So if you look at this map here, it's really small, and I don't expect you to be able to read it, but there are different areas in the country where different fungal organisms are common. And so, quite often in your histories, you will ask, what part of the country do you live in, or have you traveled to another part of the country? If you have some sort of a weird lung infection, because you can get different fungi that are present in different parts of the country. The most common are coccidiomycosis and histoplasmosis. And you you can get people who have these things and don't know they have these things. And later on, you'll get a chest X-ray, like, preoperatively or whatever, and you'll see this really nasty looking spot in the person's lungs, and you'll think, gosh, what is that? Is it, tumor, lung cancer, whatever? And as it turns out, it's an old fungal infection that has walled itself off. So anyway, just wanted to mention that these things occur, and most often don't cause too much of a problem other than an acute illness, and then it's over, and then it can leave some scarring. When it's a problem is when people are immunocompromised and they get those opportunistic fungal infections. What's up there in that first statement about an overgrowth of organisms normally found in a body. So if you think about it logically, people who have HIV, people who are immunocompromised because of cancer chemotherapy or maybe treatment with a biologic agent, and this is when you will find fungal pneumonia in those people.